ACL deficiencies, I'm sure most of us have faced some time or the other in our career. Most of them must have been adults. ACL deficiencies can also occur in children, though the frequency may not be as high. The diagnosis is different. Treatment options vary. A few eye-openers. There has been a gradual but steady increase in the ACL injuries, the incidence in children over the last 2 decades. And there's been a 2.3% gradual but consistent annual increase. The incidence is more in females for various reasons. Some of them, the alignment of the limb. Some of them biomechanical, because the way they land or the way they jump puts an extra load on the ACL. So these are certain reasons why the incidence could possibly be high in females. In the past, there's been a very strong tendency to conserve the ACL in children for various reasons, most notably being the presence of open physis. However, over the last decade or two, changes have occurred in the way we perceive these injuries. And what we're going to see now over the next 15 or 16 minutes is how our thinking has changed and how we handle the pediatric ACL injuries. This discussion is going to confine itself mainly to mid-substance tears and not to tibial spine fractures. So when it comes to an adult, we all know the treatment is very, very simple and straightforward. Most of these patients need a reconstruction. Arthroscopically, the only variations may be in the choice of graft, the choice of fixation of the graft, and minor changes in the portals and so on. But when it comes to a child, should we be looking at the same mode of treatment, or will there be a difference? Because of the open physis, do we wait till the physis closes? Till then, what do we do? So to answer these questions, I'm presenting the first case of a 13-and-a-half-year-old male child who had a pivoting injury, a non-contact sports injury. 4 months later, he sought treatment in spite of physiotherapy, which did not yield any results. He had one episode of instability during this period of 4 months. He was great tanner. We'll discuss tanner later. So traditionally, one would have waited till skeletal maturity and then opted or then given the choice to the parents of surgical intervention. During this period, different methods have been tried to avoid the current instability issues, like activity modification, bracing, physiotherapy, and so on. Question is, what do we do in this child? Do we follow the traditional concept of waiting till skeletal maturity, or do we change our line of treatment? So if I ask the panel, is there a place for conservative treatment in this patient, and if so, for how long? Is activity modification practical? Does it really work? Does bracing help? And what happens if we wait till, let's say, till the age of 15 or 16 when one could do a transepiphyseal ACL reconstruction on both sides? Anyone from the panel?
I think non-operative treatment is perfectly reasonable. I think for surgery, I think the patients and family have to be mentally, physically, and emotionally prepared to have their knee fixed up. I wrote an article that said if they are delayed in the U.S. over 3 months, between 3 months and 4 years, those patients had a 4 to 11-fold increased risk of significant meniscal or chondral injury based on odds ratios. However, some of those patients did very, very well, some of the low-demand patients. It's sometimes difficult to predict in the U.S. because we have kids doing things against our wishes with skateboards and ramps and things with an engine attached. But if you have carefully selected patients, they can do well non-operatively. I think it's an individual shared decision-making process.
Okay, so just going through literature, Lars Engebretsen from Oslo and his team did a prospective study of around 40 children, less than 12 years of age, and they used a conservative treatment protocol consisting of physiotherapy, neuromuscular stimulation, and so on. And they came out with a surprising finding that almost 91% of these children, less than 12 years of age, maintained participation in contact and pivoting sports. However, they had a 13% meniscal injuries over these 2 years, which actually is a low incidence. On the other hand, Lawrence and others have found that there's a major increase in the injury to the menisci or even to the femoral condyles. So you can get condyle injuries and the incidence is not very mild, it's significant. So if we were to look at the conservative treatment and this patient continued to have instability, how would you proceed? Sheetal, would you give importance to the Tanner scale in deciding which treatment would you use, assuming that we're going in for surgical intervention?
Yeah, I would, most of the time I would make, one is that we are not really good at assessing the Tanner stage, and I do the Tanner staging intra-op, so once the patient is asleep, then I would just check. But most of the time I've made my decision before even assessing the Tanner stage based on the age of the patient, the skeletal age of the patient, and the physis, the physis around the knee. So there is another atlas that you can use, the Hoare and Pyle atlas, which is based on the skeletal age based on knee x-rays. So I kind of, I have made my mind already, before doing the Tanner staging. But it is important because, to not base it on the chronologic age, because then you're going to be off you could be off by 2 years if you're just using the age of the patient. So skeletal age and Tanner staging together would be an ideal scenario.
So assuming that we're going in for surgery, what would you choose? What type of procedure would you choose for this 13-and-a-half-year-old boy, Sheetal?
His physis on the X-rays appeared to be pretty open, but on the MRI, the physis appeared to be not that widely open. So my choice of graft is going to be hamstring autograft. That's what I use for all my patients. The only thing that I have to decide now is whether I can do transphysial or whether I'm going to do epiphyseal ACL. So if they are Tanner 3 and above, then I don't mind. That means Tanner 4 or 5. Then 5 is, every adult is 5. So if they are Tanner 4, I don't mind going transphysial. But if they are Tanner 3 or less, then I would do an epiphyseal ACL. So but I do not treat any of my ACL patients conservative, which is against the literature and against the International Olympic Committee, which I think Ted was part of it. They came up with recommendations that waiting is okay. If you look at the Oslo studies, those are the only studies that recommend conservative treatment. Only one center has published four studies. If you look at their studies, their conservative treatment is rigorous physical therapy, 6 months of physical therapy, and then gradual release. So I have nothing against conservative treatment. I'm just saying that my patients, I don't trust them with, following all those recommendations. So
very true.
Surgical treatment and hamstring graft.
Compliance in children is not very easy to regulate, and that's one of the main reasons why treatment tends to be more surgical than conservative. Ted, would you prefer an all inside rather than all epiphyseal surgery for this child, or would you prefer to do partial transphyseal?
Yeah, so I actually, just touching base on what Sheetal said, I actually do treat any patient that is mentally, physically, and emotionally prepared. I will treat all ACLs surgically, given the incidence. So the Lawrence study, that was my resident, and so that was our publication. They did have a significant incidence of meniscal and condyle pathology. I was on the Olympic Committee study with Lars Engebretsen, and they seem to have a captured population. So it seems like a very select group of more compliant folks, and yet they still had a very high incidence of meniscal tears even in that study. So again, I treat mine surgically. And so patients with any physis that is approaching skeletal maturity, bone age 13 in females, 14 in males, I will go across the physis. So this patient that you described, a little bit of the older group, I don't mind going transphyseal, but I use a soft tissue graft only at the level of the physis.
James, any comment on the physeal sparing extra-articular procedure? Does it work?
No, I actually, when I do the Tanner 1 and 2, actually I would do the really all epiphyseal, the physeal sparing, really try to do as just horizontal to the epiphysis, big struggling and but I will try to do that. Yeah.
Any comments on the tunnel, the size of the tunnel, the orientation of the tunnel when you're going across the physis in transphysial procedures? In the size vis-a-vis the size of the graft with respect to the total area of the physis and maybe the orientation and so on?
So, I do transtibial femoral tunnel drilling when I go transphysial, so the tunnel is a little bit more vertical compared to doing an accessory medial portal. So I don't use accessory medial portal in this patient, so I go transtibial for my femoral tunnel. As far as the tunnel size, there is a controversy. If you had asked Anderson, he went with the size of the quadruple bundle, whatever the size is. If it's 6, he would drill with a 6. However, if the patient is approaching scheduled maturity, that means has 2 years left, the adult literature says that anything less than 8 has a significant higher rate of failure. So I tend to 5-fold my graft or 6-fold my graft to get to an 8. I make an attempt to do that, and I've not had issues if I'm careful about making sure that my fixation is away from the physis, that my tunnel orientation is not too horizontal, taking off a lot of physis. I have not had issues, so I will shoot for an 8 size. I don't know, I would like to see what the panel has to say.
Yes, any comments?
So I do the all-inside technique even for adults. So I would be pretty comfortable doing a physial sparing. But if I have to cross the physis, it will be on the tibial side, not on the femoral side in this patient. And,
so there's a few...
with the all-inside, so what is the construct is called graft link.
Yes.
So, even if you get a 7, it would be reasonable. Obviously, we're looking at the height and the size of the adolescent. That's equally important in terms of the diameter. So, the larger the child, you want a wider diameter graft and so on. But otherwise, if it is around 7, that would be good enough going through the physis.
So these are a few tips on choice of tunnel size, orientation. It's been proven that if a physial tunnel, a transphysial tunnel is left empty, there are higher chances of premature physial closure. So it's important that you fill up the tunnel completely, which is what you do anyway. If you're doing graft fixation away from the physis, it's important not to overtension because that's going to cause something called a tenoepiphysiodesis, and that can cause growth arrest. So these are the simple few tips when you're doing a transphysial procedure. So this is what was done. That's a tibial tunnel. You can see, if you look very closely, you can see the physis. The tunnel was made as vertical as possible. That's the jig for the femoral tunnel placement, which is all epiphyseal, using a flip cutter to create the femoral tunnel, which as you can see is entirely epiphyseal. And that's the graft which is finally in place. James, any comments on, would you have done things differently?
No, I just a word of caution about this. On X-ray, even though that we try very far away from physis, and we thought we cleared the physis, I found that sometime later, whatever thermal damage or gradually they can propagate beyond the bone, and actually this procedure not as benign as I thought originally, even though I follow all the rules. Yeah.
So it probably start the tibial tunnel a little more distally?
No, I'm talking about the femur. You see that even this is so far away from physis, but I tell you, in real life,
because of the concave.
No, the thermal damage may go a bit nearer the physis.
Okay.
I don't know. The femoral physis is undulating, but that looks beautiful to me. I think it looks good.
I mean, the tunnel is good. On X-ray, it's also good, but somehow later there's a risk of.
Yeah, I think post-op MRIs on this patient, I think it has been published. They did see that, your tunnel may touch the physis or they might be small bars, but clinically that has not been an issue. I've not seen, significant publication and complications from this surgery. So I think this patient should do fine.
I agree with you because the distal femoral epiphyseal cartilage is concave. So on the two views, you could get deceptive ideas.
So on the MRI, if you do an MRI, you might see that you are touching it, or there might be a small bar, but clinically that has not been shown to have an issue.
And Dominic, just one more point to add, that if you're going transphysial in this age group, we shouldn't use a screw. We should use some sort of
suspensory fixation. Agreed. So the next case of Ted's, a 9-year-old patient with a similar injury, a non-contact pivoting injury, symptoms, pain, restriction, swelling of movement, swelling of the joint, wide open physis. We've covered most of this in the previous case, but how would you approach this, James? 9-year-old, wide open physis.
Yeah, I
would
think
you consider?
My youngest was no doubt is tenor 1. It was 10 and a half. So I never operate on anyone below 10. I mean 2 digits.
Ted?
Yes, I think we've covered the principles and concepts, and so functionally a physeal avoiding surgery in this case. And then you showed an elegant femoral all epiphyseal tunnel. And then on the tibial side, just raising your hand is what I would do, and make it all epiphyseal on the tibial side as well.
Sheetal, you wanted to say something?
Yeah, for patients less than 10 years of age, if their tibial physis is tibial epiphysis size is small, I would do, no tunnels. So I would do a physeal. I don't know what you mean by physeal sparing, but I would not do I would do over the top, the Macintosh or McKaylee-Coker procedure. That is what I do for kids less than 10 years of age.
Okay. So I'll just rush to the other side. So this is what was done in this case, an all epiphyseal ACL reconstruction. The first, that's the placement of the femoral tunnel, as you can see here, using a fluoroscopy. You need fluoroscopy for all epiphyseal tunnels. And this is the tibial tunnel, as you can see, avoiding the apophysis of the proximal tibia. So once you have those in place, then it's not very difficult. And again, suspensory fixation. You don't want to cross the physeal cartilages. Post-ACL rehab. How would you handle post-ACL, Sheetal? In the first month, what would you hope to achieve?
For the kids that are less than 10 that I do the ITB over the top, I put them in a cast for 3 weeks. If I do an epiphyseal ACL, which is typically 10 and above, then I just put them in a immobilizer. Their weight bearing gets tolerated, and they start therapy in the first week. So there is no restriction in range of motion, though my goal is to get 90 degrees in 3 weeks and 120 by 6 weeks. The reason to cast the younger patient is because the fixation on the tibial side is suturing to the periosteum. So I want that to heal. So I would cast them.
Weight bearing?
Weight bearing gets tolerated with crutches.
Immediate,
yeah.
Okay. So subsequent to the first month, when would you permit the child to get into running activities, jogging, and progressively more and more aggressive activities? James, any comments?
They don't listen to me anyway. Yeah, so you find that really the earliest ever you let them start doing like cutting, all that will be 6 months, minimum 6 months. Otherwise, before the graft heal. But I found that a lot of them, if they do well, after 4 months, they will start doing pretty higher level activities, and which is a bad sign and good sign at the same time. Good sign meaning your surgery is good, but the bad sign they will get the re-injury soon.
I think what you said is very relevant. Children don't listen to you because what happens is their attention span is poor, their concentration span is not very great, and because of that you need to put these children on a supervised exercise protocol. Leaving them to exercise on their own is not going to work. And what's very important in these cases is neuromuscular control and neuromuscular stimulation, which really is important. How would you decide when to allow a child to return to sports? Are there any criteria that you'd follow, Ted?
I mandate a 9 months before, in terms of time, 9 months before return to sports. We make them get 90% of the strength of their unaffected extremity, which we believe is 100% of their pre-injury strength. And we make them do a series of hop tests to pass a number of tests. And some kids just functionally will never get to pass all of the 4 different hop tests that we have them do. And in those scenarios, I tend to say, well, you're just taking a greater risk when you return to sports for getting a re-injury. So it's at least 9 months. They have to have their strength fully returned, certainly their motion returned, and then pass hop tests.
So some of the series have shown a very high return to sports of almost 90%. 80%, which is more than in case of adults. The rate of re-tear has been correspondingly high as well. The earlier these children return to sports, there's been a correlation between a higher incidence of re-tears. Sheetal, you agree with that? This is Travis Decker and others.
Yeah.
They found.
So that is true, but that is adult studies. So you have to extrapolate from the adult studies. So the studies show that later you have them released to sports in the first year. The later you go and release them, the lesser is the re-tear rate. So the more you can delay the return to sports, that's better. There are a couple of things, for female athletes especially, there are preventive programs that we use, we have a program at our hospital, and a lot of places have preventive programs, which are mainly neuromuscular training programs. So before we return them to sports, it's an optional thing because they have to pay for that. But if they get enrolled in that program, they can teach them how to jump and land. And then there is a questionable role of using bracing when they're going back to sports. It depends on what sports they are doing. Some of the sports has not shown any effect on braces, and some of them, like if you're doing skiing or football, that has shown to decrease rates of re-tear. So those are the things I would discuss with the family. But if they are willing to postpone returning to sports as much as they can in the first year, that would be beneficial to them.
So I'm just going to cut across all these complications. Which are the complications you'd pay more attention to? Very briefly, Shreyas? So any measures? We've discussed growth arrest. And what about the others? Re-tears of the ACL? Any way by which you can...
The risk of re-tears is high, which is why, as James and Sheetal mentioned, we need to really go slow.
You'd prefer to delay return to sport?
Absolutely, yes.
I think the arthrofibrosis is also a real risk. You want to make sure that you get them started in therapy and you monitor their progress, and because the outcome after an established arthrofibrosis is poor, so it's better to prevent arthrofibrosis. So you should get them going early.
Okay. So the last but most important, I'll just take a minute. Okay. The last but most important is prevention of ACL injuries. Is there any way by which these injuries could be prevented? There have been many studies being carried out over specific training programs, the FIFA 11 Plus and so on, which has shown a major increase in the incidence of ACL injuries in patients. So it's very important that this is instituted and implemented in training protocols. So just to cut the whole thing, to put everything in a summary form, prevention of injury is very, very important as far as the ACL is concerned. Tendency to be more operative in treating these patients is increasing, mainly because of the possibility of meniscal tears and chondral damages. Reconstruction techniques, whenever adopted, need to keep in mind the growing cartilage, and rehab and return to sports need specific guidelines, which are very important. Thank you.